We are live now.
So, good evening, everyone, and we are in the second round of BOS Rising Star of 2025, and we have 10 contestants today who have sailed through the round one, where we had more than 50 participants. So, to introduce the concept and introduce the judges, I'll invite Dr. Neeraj Bijlani today. Neeraj, over to you.
Yes. So, BOS Rising Star contest was started frame in mind to identify the future great speakers or future great presenters of the Bombay Orthopedic Society. So, with this in mind, this is now the third year running. We started in 2023. It was started by that time President Dr. Sanjay Dhar, and it is now third year. So, first round is specialty wise, where everybody is judged according to their specialty. Second round is a which where you have all reached out of 30 people, only 10 people have been selected, and where you have all reached. This is a general round where the topic is selected by the speaker or the presenter themselves, and you have 7 minutes for presentation and 3 minutes for Q&A of the various judges which we have today. So we have judges from all specialties from all over Bombay, beginning with Dr. Anand Thakur, who's a very senior orthopedic surgeon, and as like to call him, an octogenarian of the Bombay Orthopedic Society. And then we have with us Dr. Harshad Argekar, my very good friend, and he was the treasurer with me in the Bombay Orthopedic Society in 2022. We also have current committee member Dr. Jayesh Bhavishkar, who will be the future VIROC secretary of the next year. He's an arthroplasty surgeon. We have Dr. Satish Mutha, who's mainly a trauma surgeon, but I also consider him as a general orthopedic surgeon because he has experience of doing multiple surgeries. He has also been the treasurer with me in the year 2023 when we actually started the Rising Star contest. And last but not the least, we have Dr. Sandeep Patwardhan, though he's from Pune Sancheti Hospital, a pediatric orthopedic surgeon, but he is basically a Bombay boy, and he has been a very important part of all Bombay Orthopedic Society VIROCs. So I welcome all the judges, and I just repeat, and we also have with us our own secretary of Bombay Orthopedic Society, Ashish Phadnis. So with this, I would hand over back to Ashok to start the session and just explain the presentation format and the Q&A.
Right. So, thank you, Neeraj. For the judges, this is a round two of BOS Rising Star. All the Rising Star presentation are based on literature review. However, in round two, the contestants were allowed to select their own topics and make the literature review out of that. So they're not going to present cases or their experience, but literature insights on the topics that they have selected. In round one, we gave them topic. In round two, they have selected the topic. So they are more responsible for the presentation in that sense. So marking is based on their presentation of 7 minutes and Q&A of 3 to 4 minutes. Um, since we have 10 contestants today and we have 5 judges, I mean, judges can ask queries based on the specialty of presentation or in general if they wish to. So with that, I'll start the session. Dr. Yash, you can share your screen and start your presentation. I'll keep the timing on my phone, so I'll let you know if you're exceeding the 7 minutes time. Yes, you can see your presentation. Go to slideshow mode and we can start.
Sir, I am on slideshow mode, sir. Is it visible?
Yeah, now it is visible. You can start.
Good evening. I am Dr. Yash, and I'm going to be speaking about the role of ankle replacement and ankle fusion in end-stage ankle arthritis. But how do we get there? So if an ankle trauma like this presents, and if it is mistreated or malaligned, then that will eventually lead us to the end-stage arthritis, post-traumatic being the most common etiology. What options do we have for this? It can vary from conservative all the way down to the operative treatment with arthrodesis and total ankle arthroplasty. Ankle arthrodesis was first done in 1879, and since then it has established itself as the gold standard for end-stage ankle arthritis. This is probably because it has given very good fusion rates, a good satisfaction rate for the patient, as well as a modest complication rate of 11.2%. It is in patients with arthrodesis which has been done. This JBJS review in 2023 has shown that 24 to 100% of the patients with an arthrodesis will end up with a subtalar arthritis at some point. However, this is a clinical radiologic mismatch because only 24% of the patients end up being symptomatic. Adjacent fusions are required in 5.6% of the open arthrodesis group, according to this study, which involved 7,300 arthrodesis candidates. And hence, there was a question raised on the long-term reliability of ankle arthrodesis because of the premature arthritis, the pain, and abnormal gait patterns which were associated with it. Hence, alternative, the new kid on the block, total ankle replacement has come into the picture. But does the evidence match the hype of this? This was a narrative review of PubMed indexed articles of the last 10 years. This was a 2022 registry review of all the global joint registries pertaining to ankle, wherein they have given a 77% survival rate of 10 years for overall survival, along with a 16% revision rate. However, a subgroup analysis for only third and fourth generation implants, which are currently in use, improved this 10-year survival to 84% as opposed to 69% for the older generations. Similar study, third and fourth generation implants only, meta-analysis, pooled survival of 10 years is 81%. Multiple other studies on specifically fourth generation implants, all published from 2023 to 2025, have given a survivorship of north of 90% at an average of 5 to 10 year follow-up, which is gradually approaching that of a total knee and a total hip replacement survivalships, which we have at present. This review article in 2024 has given a varied complication profile to both total ankle replacements as well as fusions, and has attributed the reoperation rate to these complications, which is more in ankle replacement. However, if this was analyzed on a subgroup basis on only the recent articles with recent implants, this difference became insignificant. The range did improve by 4 to 14 degrees after an ankle replacement. However, it was modest, and gaining range is not really the aim of an ankle replacement. As far as the patient-reported outcomes were considered, both gave equal results. This 2024 narrative review gave a 90 to 95% survival at 10 years and also dealt with three major problems. TAR in the young age group, they have suggested that yes, there are mixed reports. However, because there are improving functional and clinical outcomes, it does warrant eligibility to consider TAR in the younger age groups as well. As far as obesity is considered, yes, there is a reduction in functional scores when compared to the non-obese cohorts, but still the pre-post analysis shows a significant benefit in pain and PROMs. It has also addressed deformity, and we are now able to address much larger coronal plane deformities all the way up to 35 degrees with similar pain function scores as well as survivorships. Another study has shown that there is a 3x increase in total ankle replacement incidence from 2010 to 20, but the revisions have not increased in the same proportion, and hence this probably reflects better outcomes over the years. So eventually, who wins the battle? This RCT was performed in this decade and was published in 2023. It's as of now a 1-year follow-up study has been published, which is still in progress. Function-wise, fixed bearing TARs were much better than ankle fusions. Range of motion, also ankle replacement does better. Complication-wise, wound issues are more in the TAR subgroup, with the revisions, early revisions being lesser in the TAR subgroup as compared to the ankle fusion subgroup. Cost-wise, TAR does save costs when there is a extrapolation to the lifetime horizon in terms of the quality life years gained. Hence, this study may not prove the superiority of TAR, but it definitely proves the non-inferiority of TAR as compared to ankle fusions. This study, 2-year follow-up study, has suggested that revisions, complications, as well as amputations are lower in the TAR subgroup. Another systematic review of 20 papers has suggested that nearly 70% of the papers have suggested that there is no difference in the patient-reported outcomes. Gait analyses have suggested that kinematics, kinetics, and spatiotemporal parameters are much better in the TAR subgroup. A summary of all of these has been given in this paper, wherein it has suggested that TAR does significantly better in terms of gait range as well as function, similar to ankle fusion in terms of pain reduction, PROMs, and survivorship, and probably a little bit worse in terms of revision rates. As far as decision making is considered, this article published in the last decade has shown that there is a definition of an optimal patient, which is a low demand, non-obese patient, a slightly older age group with good range. However, we don't always end up getting such a patient in clinical practice. And hence, they have considered that age and BMI are not absolute parameters, but need to be seen in light of other parameters. Vasculopathy definitely needs to be considered, analyzed, assessed, and treated before going ahead with the total ankle replacement. And they suggested that in a case of a bilateral arthritis as well as a patient with hindfoot arthritis, ankle replacement does better than a fusion. This study has attempted to stratify the complications. It has suggested that a certain group of complications qualify as a high risk complication, and hence, if any of these occur in prospect of follow-up of the patients, then they are likely to have a lower TAR survivorship. Another article which has helped us in decision making is this article, which has attempted to stratify the indications and contraindications, with the indications being a good indication is 20 to 25 BMI, a varus valgus angle below 35, and a good range of motion. They have attempted to stratify these in major and minor criteria and have attempted to make decision making easier for us. They have said that thoughtful balancing is the key to patient selection. And if there is any doubt even after this, then it is better served by doing a fusion. Patient selection is the key is my take-home message from this presentation. Thank you. These are my references.
Thank you very much, Ved. You finished well in time. I'll invite the judges for queries. Thakur sir, you can start.
No, nothing to ask.
Okay, any other judges you can ask? Devesh. Yeah, Satish sir, go ahead.
Hello.
Yes,
sir.
sir.
Yes, so you presented n number of studies and all very interesting. I believe there are one or two studies. Did you come across any of them of their reliability in the Indian scenario where, activities like walking on uneven surface and other things are concerned? Does TAR
Yes, sir.
work better than a fusion?
Yes, sir. So, for the purpose of gait analysis, it was definitely better. And walking on uneven surfaces is definitely a better thing in TAR because subtalar joint is in an ankle fusion when we have to only rely on the subtalar joint and the ankle varus valgus angulation, which is there in plantar flexion, is reduced. So that amount of stability loss will be there, and that is eventually going to lead to more difficulty in uneven surfaces, and hence an ankle replacement does much better in terms of stability of walking in uneven surfaces as well as gait parameters, sir.
Okay. I think that's
Any other questions?
So I have a question. What is the
Yes.
learning curve of, getting your ankle replacement right? Is it technically challenging surgery or is it a relatively straightforward surgery to learn and get consistent results?
Sir, in one study to get consistent results, they said the learning curve comprised of 30 total ankle replacements. After 30, there was no significant difference between the complication rates of the same surgeon done at different points in time. So 30 is the number which was suggested in a study. But yes, there is definitely a complicated learning curve, a steep learning curve associated. And with expertise, the outcomes get gradually and progressively better, sir.
Okay, Yash, can I ask a question, Dr. Patwardhan here?
Yeah, go ahead.
Yes, sir.
So, your 10-year survivorship that you mentioned for total ankle replacement getting there.
Yes, sir.
So, was it related to all ankle pathology or are you talking of post-traumatic arthritis of the ankle?
Sir, it was the all etiology survival rates, but overall, rheumatoid arthritis and a primary osteoarthritis etiology are able to have a higher survivorship as compared to post-traumatic ankles because
Correct. That is
post-traumatic,
obvious because those are low demand ankles.
yes, sir, and they would also
Then doesn't that cause a potential bias because then you're doing old people with limited activity levels, whereas you are talking of arthritis because of a badly treated ankle fracture in a younger demanding patient. Then is
so,
arthrodesis a better option in younger people then?
Sir, I would just like to reiterate that the survivorship is overall, but on subgroup analysis, the rheumatoids as well as the primaries did slightly better. But the survivorship which I mentioned was a overall survivorship. And yes, definitely, because in a young patient with a high demand, because the load cycles on the implant would be more, that would eventually lead to an earlier wear. So yes, that is definitely a consideration which needs to be given. And that is why there is so much contradiction and dilemma when studies are considered as to the ideal age before which a tar would give suboptimal results and after which it would give better results.
Yeah, because when you do a literature review like this, the message sometimes that goes out is that most people who attend Vairog are trauma surgeons who will start doing ankle replacements thinking there is 10 year for survivorship. We hardly have any patients with rheumatoid or primary OA which undergo ankle replacement.
Yes, sir.
So that I think because the elbow went the same way, and soon we will have a lot of ankles being converted to fusions in 2 3 years because the people start doing it in post-traumatic arthritis. That I
Definitely,
think
sir. The
that
age
has
needs
to
to be.
be highlighted as one of the takeaways also.
Yes, sir.
Okay. Any other questions? Meanwhile, Dr. Bhushan, please share your screen and we can start with him. Thank you, Dr. Yash. I think no questions more for
Yeah.
you.
Thank you, sir.
Yeah, Dr. Bhushan, we can see your presentation. You can start. I'll keep the time. Go ahead.
Very good evening. I will be talking today about the comparison of outcomes of cross-union with other techniques for treatment of congenital pseudoarthrosis of the tibia. Congenital pseudoarthrosis of the tibia continues to challenge the treating orthopedic surgeons since it was first described in 1891. It is characterized by poor healing of a spontaneous fracture. The primary pathology is the hamartomatous periosteum, which has increased osteoclastic activity. Historically, it has been associated with poor outcomes, and surgeons have resorted to the use of amputation after getting frustrated by multiple reconstructive attempts. The various treatment options for this condition include the use of a circular external fixator, a fixator with an intramedullary nail, a standalone intramedullary nail, use of vascularized fibular graft, or the most recent technique of cross union. All these techniques make judicious use of autograft. Today, I aim to compare the outcomes of these procedures under the following headings, which I've mentioned here. I hope to be able to tell you by the end of the talk about which surgery is the holy grail for congenital pseudoarthrosis. So this is a retrospective review of articles for the last 5 years published in PubMed, Cochrane, and Google Scholar databases. I have included case series and systematic reviews on pediatric CPT. I have excluded case reports, literature reviews, and literature on pre-fracture pseudoarthrosis and adult CPT. There were 53 studies which were identified, of which 24 were eligible for inclusion. 18 full text I was able to get hold of which 17 were original studies and one was a systematic review. So first I will talk about the cross union, which was separately but almost simultaneously described by Inho Choi and Dr. Dror Peli. This technique involves excision of the fibrous hamartomatous periosteum, use of autograft to create a synostosis between the tibia and fibula across the interosseous membrane, and fixation with an intramedullary nail and plate or an intramedullary nail with a circular external fixator. I will start by talking about the 7-year outcomes of this technique from Dr. Dror Peli, who has reported 100% union rates, 0% refractures, but 11 cases with residual secondary deformity and migration of the telescopic rod in almost 66% of the cases. This other study by Dr. Vaidya et al. And Zing et al. Conducted a comparative study between the cross union and intramedullary nailing and bone grafting. Both authors have reported 100% primary union rate, 0% refracture rate, as opposed to a lower union rate and higher refracture rate in the intramedullary nailing and bone grafting group. Time to union was also significantly lesser in the cross union group. Similarly, other studies too have reported 100% primary union, 0 refracture rate, and healing by around 4.5 months after surgery. Talking about the rates of secondary surgery and complications, they were also lesser in the cross-union group as compared to the other group in the study by Tan et al. The main issue with cross-union surgery is the incidence of ankle valgus and tibial valgus, which has been reported in up to 40 to 50% of the cases in the series by Vaidya et al. Now, this may look like a very busy slide, wherein I'm talking about the outcomes of other techniques of treatment. Just please pay attention to my words. Of the other methods reported, the success rate of the treatment was about 77 to 100%. There was a refracture rate between 12 to 40%. Time to union was between 3.5 months to 4.7 months, and a fair number of patients developed ankle valgus or tibial valgus deformities at final follow-up. Next, I want to talk about vascularized fibula grafting, which is popular in Europe. The studies in recent literature are very far and few with a small sample size. The only long-term study by Gamal et al. With 39 patients reported a 96% union rate, but 51% had stress fractures and 53% developed a tibial valgus deformity. The major drawback of the vascularized fibula grafting is the chance of donor site morbidity, with progressive ankle valgus being the most important. This ankle valgus relentlessly progresses despite performing a distal tibiofibular fusion. And in Singh's study, 50% patients needed a corrective osteotomy for ankle valgus of the donor leg, which is a significant number. Failure to union has been reported in 2 studies to the tune of around 11 to 14%. And 1 patient in the vascularized fibula grafting study underwent an eventual amputation due to failed reconstruction. In the last study, I'm going to talk about a systematic review by Dr. Anil Agarwal, which again stresses the same point that cross union has a 100% union rate, and they have reported around 22.5% refracture rate with a 4.5 month time to union. In comparison with the other technique, the primary union rates are between 65 to 84%. None of them have had a 100% final union rate. Refractures are seen in almost 30 to 40% of cases, and the probability of having a successful outcome is also between 35 to 55%. That is, only half of the cases that you operate will unite at best. Congenital pseudoarthrosis of the tibia remains a challenging problem, and we have come a long way from performing amputations for this condition. It is evident that cross-union outperforms other modalities of treatment, almost like knocking out the other opponents. However, there are caveats to this. As they say, the enemy of a good outcome is a good follow-up. Hence, secondary deformities after cross-union may be seen in about 6 to 50% of cases. Nail migration and deformities distal to the tip of the nail is a real problem. I will just talk about a case example. This boy was an 8-year-old who presented with a pseudoarthrosis of the tibia, having been operated elsewhere. The patient underwent a 4-in-1 cross-union technique with the use of intramedullary nail, cross-union with autografts, and a circular external fixator to achieve union in about 4 to 5 months post-op. However, at 2 years follow-up, as you can see, as the nail migrated, the patient developed a deformity distal to the tip of the nail and a refracture. And this again was managed with a revision 4-in-1 surgery, and it has gone on to heal uneventfully. The limitations of my study is that most studies are level 4 and retrospective studies. The population is heterogeneous with a small sample size, and long-term follow-up is missing. Thus, to take home, cross-union gives good outcomes with primary union. It is better than most modalities. Secondary deformities and refracture is not uncommon. Surgery is challenging and should be performed in a center and by a surgeon who's dealing with a high volume of these cases. Long-term follow-up of this condition is important, and I believe the search for newer treatments should continue. And we are still not yet at the point where I could call cross-union as the holy grail. These are my references.
Thank you very much, Dr. Bhushan. Sandeep sir, I think you should start with questions in this.
Hi Bhushan, nice presentation. Couple of things. Since you have only reviewed last 5-year papers, right? 22, 25, no?
Yes.
So this is the new kid on the block with very short follow-ups.
Exactly, sir.
Vaidya et al. And other Anil Agarwal have even more than 2-3 year follow-ups.
Yes, sir.
The problem with this is that primary union, even Dr. Benjamin Joseph in less than 2-year kids has reported 90% plus primary healing rates. But
Right.
what happens is that the disease, which is genetic at best, seems to come back slowly over a period of time. So more than refracture, maintenance of that union status and preventing reoccurrence of disease is a challenge, which is a biological problem which we really don't know much about even now. So it might be premature to start calling this as the holy grail, as you rightly said in the end, because we simply don't have a longer follow-up.
Yes.
And papers like Palace, which say 100%, 100% everywhere, convey a very wrong message to the person who reads the papers.
Right.
Because we've seen that whatever you do after the healing, later on the disease comes back and bites you. So till you have at least 18-year means maturity, till maturity follow, we really don't know. And maintaining, as you rightly said, the valgus and secondary deformities is a challenge. The nail migration remains a problem.
Yes, sir.
So what happens is that the classic 4-in-1, I'm sure you are also not putting BMP and thing that is described because it is too expensive.
Yes, sir.
So most of what we are doing is a Indian cheaper 4-in-1.
Yes, sir. Exactly.
So it's not we are comparing apple and orange. We are just but conceptually it is a good concept that a longer what do you call a longer span of healing across both bones will be more difficult to break again.
Right.
So way it sounds logical and it's promising, but it needs to be seen.
Right, sir.
There should be a biological stress on biological option and maybe some more literature on are there some research or studies happening at the biological level with the hematoma or drug treatment or gene therapy to tackle the primary pathology rather than just the healing.
Right, sir. So, thank you for your comments, sir. So far, based on my literature review, I did not come across any study which is trying to, target the basic pathology of the disease. There was one study which talked about some stem cell use of stem cells, but I thought because I wanted to focus mainly on the outcomes of surgical treatment, I did not dive deeper into the study and the outcomes of it. But apart
Right.
from, I could not come across any other newer modalities or newer drugs which are being treated for which are in trial for treatment of CPT.
So Bhushan, Dr. Arvikar, I have a question.
Yes, sir.
Is there any cases where this cross healing is contraindicated? Where can it be? Is it also recommended for recurrent CPTs and patients who have been operated many times before, or is it to be done in a person who's been treated for the first time?
Sir, so a cross union can be done in patients who have been operated multiple times, and based on our experience at Vadia, we have managed to salvage a few patients who have had multiple previous reconstructive surgeries by the 4-in-1 cross union technique. The only contraindication per se which comes to my mind is if the pseudoarthrosis is proximal, wherein trying to pass a graft behind the interosseous membrane, wherein you have the soleal arch and the popliteal vessels coming in. Maybe there you might have to exercise more caution while you're trying to get a cross union. Besides that, since most of the congenital pseudoarthrosis of the tibia is either in the midshaft or more distally, you can usually get away by doing a cross union, sir. That has been my experience and what I've seen here.
Okay, any more questions? Thakur sir?
Yeah. Do you have any statistics, particularly from Dorpelle's work? What is the incidence of recurrence of deformity after 3 or 4 years? Because when he says 100% every time, there is a pot full of salt nearby.
Right, sir.
So, any statistics on that? How much, how often the things recur? How soon they recur? Or nothing like this? You have.
Yes, sir. So this paper which I mentioned, in this paper, Dr. Paley has talked about 7-year outcomes of their cohort of patients. So again, they have not reported recurrence of the disease in any of the patients. The primary problem that I could understand from this paper, reading between the lines, is that 11 patients had, deformities, residual deformities, either below the pseudoarthrosis or somewhere else. And the other major complication which Dr. Paley has reported is the migration of telescopic rods, which invariably happens even if you have tried to lock the nail distally by passing wires through the eye of the nail. So migration of telescopic rod is the real problem, and it is because of the migration that what we are seeing is that the tibia deforms distal to the tip of the nail once it has migrated.
Does Pelly tell you what was the age? He followed it 14 years, 15 years of age, or just between 2 and 7 or 2 and 9? What was the longest How much the oldest patient he had in this series? Do you have any information there?
I don't remember over the top of top of my head. I can look up and let you know, sir.
Okay.
The only way Bhushan distal valgus is preventable is if you are transcalcaneal into the across the CPT.
Right, sir.
Wouldn't that harm the talocalcaneal this thing?
No, but that
Um,
the primary aim there is to get healing most of the times. And like he said, distal ankle valgus is a problem. The rod invariably migrates. There's no sure short way of stopping it. Anyhow, we can just go on with the next paper.
Go ahead. Thanks, Bhushan.
Thank you so much, sir.
Dr. Shubham, you can share your presentation and we can start. Just click on play on the top.
Good evening.
Okay,
Can you
we
see?
can see, we can hear you. Go ahead.
Yeah. Good evening, everyone. Myself, Dr. Shubham Atal. My topic for today is hemiarthroplasty or reverse shoulder arthroplasty in proximal humerus 3 or 4-part fractures. Proximal humerus fractures account for 5 to 6% of all the fractures. The treatment of choice for displaced dislocated 3 or 4-part fracture is still debatable. Traditionally, hemiarthroplasty had been a preferred treatment option in elderly. Reverse shoulder arthroplasty has emerged as a promising treatment option in the last decade. Theoretical advantage of RSA is that the shoulder function is independent of the tuberosity healing. Dr. Charles Neal designed the shoulder head prosthesis for complex proximal humerus fractures. RSA was conceived in late 1960s to 70s for patients with deficient cuff. Dr. Paul Gremont in 1985 designed the modern day use RSA prosthesis termed as the trumpet prosthesis. Subsequent design modifications have been made in both the prostheses. Since publications of first case series on RSA in 2006-2008, its use has been increased. The objectives and methodology are: this review aims to compare the outcome of RSA versus hemiarthroplasty for complex proximal humerus fractures. Relevant studies of last 10 years were searched in electronic database on PubMed and Google Scholar. The keywords used were proximal humerus fractures, RSA, and hemiarthroplasty. Dev R. Shukla, in their meta-analysis published in 2015, they included 7 studies from 2009 to 2014. The average age of patients included in the study was 70 to 80 years of age. All the studies reported that the forward elevation, abduction, constant score, and the dash score were better in the reverse arthroplasty group than the hemiarthroplasty group. The studies had an average follow-up of 12 to 60 months. Of the outcomes examined, only external rotation was found not to be favoring the RSA group. RSA was more effective treatment option in complex proximal humerus fracture in the elderly age group. Similar results were seen by the meta-analysis published by Juan Wong. And Bonville in the retrospective study included 57 cases in the hemiarthroplasty group and 41 in the RSA, and reviewed for minimum 2 years of follow-up. The evaluation was based on the constant score, the simple shoulder value, and the dash score. The clinical outcomes were better in the RSA than the HA group. Complication rates were higher in the hemiarthroplasty group. Scapular notching occurred in 20% of the RSA cases, suggesting a guarded use in the young patients. The objective and subjective clinical results at the follow-up, we can see that the constant score in the HA group was 73, whereas in the RSA group it was 83. The quick dash score in the HA group was 30, whereas it was better in the RSA group, that is 28. Of the complications, 25% in the HA group and 10% in the reverse shoulder arthroplastic group. The 11 patients in the HA group had stiffness, whereas brachial plexus injury was seen in 1 cases in both the groups. Lynn Charles, in their critical analysis review on operative treatment of proximal humerus fractures, they concluded that the RSA had definite advantage over open reduction intent fixation and hemiarthroplasty in 65 years age group or elder. RSA provides early pain relief and early return to the shoulder function. Indications for RSA and effect of timing of RSA continue to evolve. The RSA is indicated in proximal humerus fractures more than 65 years age, 3 or 4-part dislocations, and head split fractures. It is also a salvage option in failed ORIF or non-union or malunion. Either O. Johnson in the multi-center randomized controlled trial included 43 patients in the HA group and 41 patients in the RSA group. The better range of motion in the reverse shoulder arthroplasty group was the key difference. The study also stated that more benefit in the 70 to 80 years age group is seen than the more than 80 years of age group. We can see that the flexion range in the RSA patients 82% of RSA patients had flexion more than 100 degree, whereas 30% of the HA patients had flexion more than 100 degree. Coming to the constant score, only 30% of the RSA patients had constant score less than 50, whereas 55% of the HA patients had constant score less than 50. B. Israel Yaucha, in their study on acute surgical management of proximal humerus, they considered all the three options: the ORIF, the hemiarthroplasty, or the reverse shoulder arthroplasty. From 1999 to 2018, 425 proximal humerus fracture cases were included, of which 211 were managed with ORIF and 214 with arthroplasty. They concluded that two-thirds of the three-part fractures were treated with ORIF and remaining with arthroplasty. Four-part fractures were treated with RSA, which was 39%, or hemiarthroplasty, which was 32%. Malunion or hardware complications were seen 25% of the ORIF cases, 30% of the hemiarthroplasty, and only 15% of the RSA cases. Reoperation rates were low as 6.6% in the RSA group, whereas 15.7 and 17.5% in HA and ORIF group respectively. The primary RSA for fracture outperformed revision RSA for failed ORIF, which can be an important consideration for the primary treatment choice. Last nails in their randomized control study on 31 patients, of which 14 in the HA and 17 in the RSA group. The subjective and objective outcomes were measured at 3, 6, and 12 months post-op. Statistically and clinically significant superior outcomes were seen in the RSA compared to the HA group. As we can see, the constant score at 6 weeks, 3 months, 6 months, and 12 months, the abduction range, the anterior elevation, and the dash scores, the RSA group outperformed the hemiarthroplasty group. Michael van der Merwe in their study included 645 patients from the New Zealand Joint Registry of proximal humerus fractures which underwent arthroplasty, of which 427 underwent hemiarthroplasty and 218 underwent RSA. They concluded that the rates of RSA steadily increased after 2009. The RSA group had better functional scores at 5 years follow-up, but statistically there was no difference. The revision rates were lower in the RSA group. Coming to the cost effectiveness analysis of hemiarthroplasty versus reverse shoulder arthroplasty, two surgeons, the George Ostroff and Josan A. Solomon, concluded that the cost of RSA to hospital and patient exceeded that of hemiarthroplasty, but the pain scores and outcome scores in RSA exceeded that of the hemiarthroplasty group. The cost effectiveness ratio of the RSA is well below the standard willing to pay threshold. RSA is the preferred economic strategy for complex proximal humerus fractures in elderly population compared to the hemiarthroplasty group. To summarize, treatment solution for complex proximal humerus fractures is still evolving. The subjective and objective outcome parameters favor the RSA as the treatment choice in 3 or 4-part proximal humerus fractures. Indicated use of RSA and subsequent decreased implant cost will make its use less controversial. Is HA obsolete? No. It is still a bailout option in revision RSA cases. More level 1 studies are needed to outline the definite indications for RSA and assess long-term results. These are my references. Thank you, Bombay Orthopedic Society and the Rising Star organizing team.
Thank you very much. Questions from the judges? Tatisha, you want to start?
I will
Yeah,
ask.
so,
Go
okay,
ahead, sir.
Is there any indication uh, or a priority of doing RSA or HA? Is it age related? In a young patient, would you offer HA or you want a RSA? And in this respect, from this point of view, is there any finding in literature that young patients will go only for RSA or HP or whatever the preference is?
So the implants are, if we look at the implant survivorship of the RSA, it's 95% for 10 years and 15 years. So I guess in young patients, the RSA would not be a better option. It would be a open reduction internal fixation in young patient. But considering the elder age group, where we expect not more than suppose 15 or 20 years of lifespan and not much demand, the RSA will outperform the hemiarthroplasty.
If it is 15 to 20 years, then a younger patient, would you ever offer a RSA to say a 40-year-old gentleman who has a very smashed head, or you would still try to reconstruct it?
I will still try to reconstruct, sir, in 40 years of age group.
Okay. And then when time comes, you will do a RSA, is it? Okay, that's fine.
Yeah, in your presentation, you never mentioned what is the age limit where you consider RSA or whether you consider HEMI. Really not age stratified it, because in a young patient, both these options are not available to us. You will always do an ORIF rather than doing any kind of
Uh,
replacement. That should have
Basically,
been specified in your
sure, sir.
presentation.
So,
Okay.
Dr. Shubham, can I ask a question?
Yes, sir.
Shubham, your paper, your review trying to compare Hemi with a reverse is a debate like comparing bipolar with a total hit. I mean, the verdict is more or less clear. There is no point in comparing them all over. The real challenge is comparing an RSA with a Hemi in an extremely elderly population where you can't fix, where Hemi is an easier option, a quicker option, versus RSA, which is a technically demanding option in a 75. See, when it is a 65, 75-year-old, there's nothing to think. But when you're treating a 75-year-old or a 80-year-old who's relatively fit, you don't know whether you want to do a RSA or you want to do Hemi, because you don't know what happens 5 to 10 years. So I want to, is any of your paper telling us about these two processes in the extremely elderly age group
Yes, sir.
with the
Actually,
low functional demands? Is there any difference at 5 to 7 years? Low
if,
functional.
yes, sir. If we don't look at the functional demand, if we just look at the age group of the patients, so there was one study which considered the ASA scores. So if ASA scores are 1 or 2, so if in ASA scores 3 and 4, RSA was a better option than the hemiarthroplasty group, as they considered. So ASA, if we considered, so if like a patient is having comorbs, elderly, osteoporosis, uh, just from the point of comorbidities, as you said, the age 75. So RSA outperformed the hemiarthroplasty in that group age group, sir.
Mm. Shubham, are you aware of a recent paper which talks of open close reduction and K-wires in elderly population being comparable to RSA with PROMs?
No, sir. Actually, my keywords for basically I've just focused on the papers of hemiarthroplasty versus
Yeah, that
RSA.
is the problem. You start with a premise of which is a bias.
Sandeep sir, we can't hear you.
I said that if you start
Once
search
finished.
premise that is a bias, then the other part of conservative PROMs or treatment of 3 and 4 part in septuagenarian 70 plus people, then you are missing out half the literature.
Sir,
Where
if
even nowadays people are talking of close reduction K-wire being as comparable to RSA with low demand older osteoporotic patients with high risks. So from a surgeon's perspective, always RSA is going to outperform, as he said, after 2009, because number of companies making RSAs has multiplied.
yes, sir, maybe the reason.
Okay, any other questions? Okay, so thanks, Dr. Shubham. Dr. Varun, you can start your presentation. We can
Sir,
see your
good.
screen.
Yes, sir. Good evening, sir. Am I audible?
Yes, you're audible.
Yes, you're
Yes, sir.
audible.
Okay. Good evening, respective faculty and judges. I would like to thank Bombay Orthopedic Society for giving me this opportunity. Today, I will be talking on radiological and functional outcomes of four-part proximal humerus fractures. Does the multi-lock nail really challenge the gold standard Philos? As you know, four-part proximal humerus fractures are notoriously challenging, especially in elderly osteoporotic bone. The Philos is the traditional gold standard, but has several issues such as varus collapse, cut-throughs, and revisions. Plates are a longer lever arm, load bearing, nails are central, implants, load sharing, shorter lever arm, more biomechanically stable. The multi-lock offers proximal anchorage, larger subchondral screw arch, and a screw-and-screw stability. My aim is to review literature comparing multi-lock versus the Philos in four-part patterns. As we can see in case 1, case 2, and case 3, post-operatively, we have got all reduction parameters with the Philos, but they still tend to fail in various intra-articular screw penetration and implant cut-through.
कौन मुर्गी नहीं है?
The spectrum of
कौन मुर्गी
four-part
नहीं है?
fractures are varied. You have the relatively good ones, which have a good medial continuity, a good bone stock. We have the four-part fracture dislocations with osteoporosis. We have the head split fractures, and we also have the metaphyseal diaphyseal combination with osteoporosis and head split. So they tend to differ and behave differently, but the thing common with them is the plate will not hold the reduction in any of these fractures. It is a constant battle against varus. And this was my methodology, my inclusion-exclusion criteria. Coming to my review of literature, this landmark paper by Pascal Bolu gave a crucial analysis about the medial continuity and proximal humerus fractures. And any of the proximal humerus fractures which were plated, which had a loss of medial continuity, showed an increased incidence of articular screw penetration, varus collapse, and secondary surgeries. So plating should only be done if medial continuity is intact. If you are going for a plating and there is no medial continuity, you have to augment it with an anterior medial plate or a strut graft. Coming to this paper by Euler et al. In 2017, where he spoke about the biomechanical evaluation of the nail in cadaveric bone models, which were loaded with varus and torsional forces. These implants showed no screw back out or screw cutout or any other signs of implant failure. As you can see in these images, the bone has been crushed, but the implant has stood its ground. Coming to this paper in 2021, in which the locking nail was compared with the locking plate fixation, the only complication which was seen with the plate was secondary fracture displacement without implant failure and malunion. None of these complications were seen with the nail. Coming to the length of the Philos screw using a 3D CT scan, this study by Menfi Kuang showed that Philos plates had higher incidence of intra-articular screw penetration and varus collapse. According to the study, the only way to get the most accurate way of screw placement is using a CT intra-op. Of course, this is not required with the nail. As we see these two images, we can see the nail has a screw-in-screw screw and screw, which prevents screw cutout. Also, there is a polyethylene bushing within the nail, and also the screw arc of the nail is much physiologically stable compared to the Philos plate. Coming to this study by Dr. Andy, where the functional outcome of the nailing group at 12 months, as we can see, the abduction is almost 141 degrees and the forward flexion is 144 degrees. This is giving you a full range of motion in a four-part proximal humerus fracture. Coming to this graph where we compare the rehab with the Philos and the multi-lock, even though both of them are doing similarly well at 12 months, we can see that the group with the Philos is achieving almost full range by 4 to 6 months, which is getting patients back to their daily activities at a much faster rate. Coming to this landmark paper in 2021 by Wu et al., where he compared multi-lock with the Philos, the multi-lock nail had much better constant Murley scores, ACEs scores. There were no revisions required with the multi-lock rate. The Philos plate had a higher reoperation rate. This paper by Patrick Boyar, again comparing the nail to the plate randomized control trial, shows that the VAS scores were lower in the multi-lock group. The constant Murley scores and the ACE scores were significantly higher in the nailing group, showing a better functional outcome. Complications were only seen in the plating group. Revision surgery was higher in the plating group. Coming to this study by Guyon et al. In 2021, which shows that the multi-lock nail is superior to the Philos plate in terms of blood loss, operation time, complications, union time, and change in the final neck shaft angle. So to summarize my studies, the multi-lock nail has a shorter operative time, lower blood loss, lower VAS scores, better functional scores, better range of motion, almost no, it maintains your neck shaft angle. There is no varus collapse, hardly any implant complications as screw cutout is virtually impossible. Union time is faster, reoperation rate is much less. Just to show some case examples, we have a four-part proximal humerus fracture. As we can see the CT scan, we have a head split component. This is my post-op X-ray, good valgus reduction. This is the X-ray at full union, and this is my patient's functional outcome. Over here, we have a 70-year-old male with severe osteoporosis. As we can see, a multi-fragmentary head split fracture, a Sheebel's type 4. These are our intraoperative reduction images. These are the final X-ray. We got a good valgus reduction. As you can see, the nail holds on to the reduction. There is no change in the reduction compared to the immediate post-op. And this is my patient's functional outcome. Another X-ray, 55-year-old male, the most dangerous variant of a proximal humerus fracture, severe metaphyseal diaphyseal combination. As you see this CT, you can see there's a bad head split fracture. Again, we went ahead, did a long nail for him, and again, it got good union. So to summarize, the multi-lock nail is superior biomechanically. Secondary displacement almost never occurs. Implant-related complication never occur. It is the solution to all types of proximal humerus fractures. Rehabilitation is much early. I would like to conclude and say the multi-lock nail is biomechanically more superior. It maintains the reduction much better to the phyllos without any change in the neck shaft angle, lower surgical morbidity, faster rehabilitation. Current evidence indicates that the multi-lock performs better than the phyllos plating. This is studies over the last 10 years. However, larger term multicentric randomized control trials are needed for definitive gold standard status. These are my references. Thank you, sir.
Thank you very much, Varun. Questions from the judges, please.
You showed 4 cases. What is your follow-up on those 4 cases?
Sir, we have followed them up to 2 years now, and all
Okay.
of those patients are doing well. They got an abduction, overhead abduction, and they've returned to their daily activities, and there is no change in the X-ray compared to the first post-op X-ray.
Okay. You showed a case with a head split. Now,
Yes,
how
sir.
do you explain to us the screws that you passed through the head also compacted those split head? How did that get together and stay together? Is
So
there a
so before we take our entry, we get a reduction of the head, and the entry point of my proximal humerus nail is through the center of the head. This itself is creating a proximal anchorage in the head, which is holding the reduction of the head. After this, we are getting the tuberosities into position and then passing our screws through the nail. And along with this, we are getting a screw and screw. So within the bolt, we have an option to put another locking screw. But the main reduction, sir, is held by the nail itself, as the nail is entering
Varun,
through the...
sir's question is that the head is split.
Yes, sir.
How have you ensured that with a split head your screws are still holding? Am I right, Thakur sir?
yes, that's right. How did you
Okay.
produce a compression between those two portions of a
Head
hemisphere?
fragment.
Yes, sir. So we have got the reduction of the head. We have hold the reduction of the multifragmentary head with K wires. We have then taken entry and then we've passed the screw, sir.
Okay, all right.
Yes, sir.
So, can I ask a question? Varun,
Yes, sir.
nice presentation. Of course, you have lovely cases at Tejaswini.
Yes, sir.
But one thing that you have said that there are almost no implant or procedure related complications. We
Yes, sir.
all initially had the fear that we are violating the supraspinatus tendon, but now we are coming over that. But
Yes, sir.
now there is a 20% long head biceps tendinitis incidence because you have to enter through the cuff interval. And the anterior screw also goes through the biceps tendon groove. The
Yes, sir.
injury journal 2024 says there are 20% incidence of long head biceps tendinitis. What do you have to say on that?
So the long head bicipital tendinitis is only due to the anterior screw, sir. We don't use the anterior screw until we require it. We use our medial screws and our oblique screws, and we try to get a calcar screw. And through our medial lateral screws, we try to get a screw in screw. We leave the anterior screw only if it's required. So without putting the anterior screw, the nail is intramedullary. So bicipital tendinitis is not a complication. We don't see that in any of our patients. The anterior screw, we always leave it for the end.
So that is not the main cause is your entry, which is close to the cuff, the rotator cuff interval, where the
Yes,
biceps tendon lies.
yes, sir.
And the head, the acromion invariably, tends you more and pushes you more anteriorly and closer to the tendon. So
Yes, sir. The entry is through the rotator cuff. We have to split it longitudinally through its fibers, but we have no incidence in our cases of bicipital tendinitis. So.
Okay. Thank you, judges. And Thank you, Varun. I'll
Thank you, sir.
invite Dr. Urvil to start his presentation now. Dr. Urvil, you can go ahead.
Am I audible, sir? Is my
Yeah, you're
presentation
audible.
visible?
You're audible. Your presentation is seen. Go ahead.
Good evening. My name is Dr. Urvil Shah, and today I will be talking about the medialized and lateralized reverse shoulder arthroplasty designs. In the current era, the number of cases of reverse shoulder arthroplasty have been increasing. This is evidenced by this graph, which shows increasing trends in various registries. The indications have expanded from the initial cuff arthropathy to proximal humerus fractures, arthritis, tumors, revision cases, and AVN. There are multiple design options available in the market. But yet, shoulder surgeons are confused regarding the medialized and the lateralized design of the RSA. To understand this in detail, we need to know and go back to the Gramont's original RSA design. In his design, he medialized and distalized the center of rotation. This improved the deltoid force. The center of rotation was at the bone implant interface, which lead to lesser shear forces. The distalization of the deltoid causes retensioning, and the prosthesis was semi-constrained with a constant center of rotation. In spite of its longevity and relatively good outcomes, there were several problems with the medializing. They were scapular notching, instability and dislocation, inadequate tension of the cuff leading to restricted rotation, and loss of the shoulder contour. Therefore, to understand the lateralization, I did a detailed narrative review of the literature, and I would like to discuss this in various categories. Among the methods of lateralization available, they have been in the following format. On the glenoidal side, we can do a metal increased offset RSA, which is in the form of implants, for example, at the augments using base plates, the glenosphere level, or doing a bio RSA, which is a bony increased offset RSA, wherein we are using some form of bone graft. On the humeral side, lateralization could be achieved by using a lesser neck shaft angle stem, example a 135 or a 145-degree stem, as compared to a 155-degree stem, which was used in Gramont's original design, using a curved stem over a straight stem, and an onlay design over an inlay design. In the inlay design, the stray sits flush onto the humeral cut, whereas the onlay design, it's not so, and multiple offset options are available. There's a bipolar or global lateralization, wherein lateralization is done at the glenoid and at the humeral level. Now, to talk about the various designs available, we need to understand this picture given by Verdal et al. Line A corresponds to the humeral diaphyseal axis. The line B is the line present at the center of the humeral cut. C is present at the pivot point, which is the deepest articulation between the glenosphere and the insert. D is the center of rotation, and E is the center of the base plate. Accordingly, Verdal et al. Says that there is a humeral offset, which is A to C, comprising of two components, AB being that from the humeral stem and BC being that from the insert. Whereas on the glenoid side is C to E glenoidal offset, wherein CD is the contribution from the glenosphere and D to E is the contribution from the base plate. Accordingly, Verdal et al. Compared the lateralization of various implants with respect to delta 3, which is the implant which was based on Gramont's original design. Accordingly, if an implant was less than 5 millimeters lateralization as compared to delta 3, it was a medialized implant, and if it was more than 5 millimeters, it was a lateralized implant. Accordingly, there are four broad categories of implants designs available. Out of this, it is the lateral glenoid medial humerus and the medial glenoid lateral humerus, which are favored. Now, talking about the various biomechanical studies, William Liu et al. In his biomechanical study showed that a humeral lateralized design implant had lesser muscle forces generated for the same arc of movement as compared to Gramont's design. He also showed that a humeral lateralized design had maximum compressive forces leading to improved stability, and a glenoid lateralized design had relatively higher shear forces. This is an article by Michael Bursick et al., wherein proximal humerus four-part fractures induced in cadavers, and they managed them with RSA. They showed that lateralization improved the stability, and even after 6 mm of lateralization, the tuberosities could be tied back up. Now, talking about the various outcomes in the range of movements, multiple systematic analysis and meta-analysis have been done. All of them tell us that a lateralized RSA is associated with lesser scapular notching, better rotations, better outcome scores in the form of the constant score and the ASIS score, lesser pain, lesser heterotopic ossification, and an increased deltoid wrapping angle. Now, what is the deltoid wrapping angle? In this photo, you can see as the lateralization increases, there is increase in the horizontal force vector of the deltoid. This leads to compression and improved stability. Pascal Beaulieu et al. Compared bio-RSA with that of the Cremont design. And they showed that not only was there an improvement in the outcome scores, but there was better range of movements, lesser notching, and lesser loosening with that of a bio-RSA. Wasim et al. Compared a bio-RSA with that for use of metal augments to lateralize, and they showed that metal augments had relatively lower rates of revision and scapular notching. Theresa Park et al. Showed that in spite of 8 mm of glenoid side lateralization, the acromial risk of acromial stress fracture was less, especially when a 135 inlay humeral implant on the stem side was used. Therefore, now, if you have to consider the merits of a lateralized RSA, is associated with decreased capillary notching, improved rotator cuff and its tone, improved deltoid wrapping angle and stability. However, it has its demerits of excessive lateralization, which could possibly cause acromion fractures, or difficulty in reduction intraoperatively, possible neuropraxias, and increased shear forces, which would cause loosening. So now we are in a dilemma. Are we or are we not lateralized? To answer this, we need to know how much to lateralize, and this can be given by the Goldilocks principle. There is not too much, not too little, but just right. To see this to get to the sweet spot, Stephen Boyer et al. Suggests the patient-specific lateralization and use of planning software. They say that up to 5 to 10 millimeters of lateralization is well accepted, and humeral lateralization should be done on the basis of the glenoid lateralization. A distalization of more than 40 millimeters is associated with acromion fractures. They also says that the patient, if the age is more than 70 years, there's osteoporosis, or the patient is short stature, we should not offer too much lateralization as there's a risk of acromion fracture and loosening. On the other hand, a high demand individual, which requires stability and range of movement, more lateralization should be offered. Filippi Valenti et al. Assessed their lateralization with the help of a lateral shoulder angle, which is the angle between two lines, one line connecting the acromion to the glenoid and the other connecting the acromion to the lateralmost aspect of the humerus. They found out that when the ACES score was more than 76, it was associated with good outcome, and it was seen when the lateral shoulder angle was between 79 to 93. Therefore, in conclusion, I would like to say that a lateralized RSA has definitive superior outcomes over the Gramont's medialized design. We should offer a patient-specific lateralization. Up to 5 to 10 mm of glenoid lateralization should be done, and the humeral lateralization should be catered to intraoperatively. Excessive lateralization could be associated with acromial fractures or a difficulty in reduction. These are my references. Thank you.
Thank you very much. Questions from the judges, please.
So, Dr. Urvil, can you tell us the correlation between lateralization and acromial fractures?
Sir, lateralization, as such, there is no, the acromial stress fracture incidence is almost 7 to 10%. And they have seen that they can go up to 20% with lateralization. However, multiple studies have shown that up to 8 mm of lateralization is well accepted. But the risk of acromial fractures could be more in a short statured individual or osteoporosis patient or an elderly patient. Sir.
And
But
how
as such-
clinically significant is acromial fracture?
So the acromial fractures have a really poor outcome, have shown to have a really poor outcome if they develop in a reverse shoulder arthroplasty, because the patient often complains of pain, and since the deltoid is attached to it, there's limited abduction, and the other range of movements are also restricted. More than that, sir, the acromial fractures are also difficult to treat. Typically, a type 1 fracture is managed conservatively, but type 2 or 3 should be managed surgically. And outcomes after 6 weeks, if the fracture is not treated within 6 weeks, they're shown to be really poor, sir.
You said short stage people, short statured people. Can you quantify that? Who the short stage person?
Sir, as such, I could not find specific articles regarding the short stature, but I've spoken to multiple shoulder surgeons, and many of them say that they just see if it's 5 feet or less, and they consider 5 feet or less as short stature, and in those cases, they really avoid lateralization. But as such, sir, I could not find specific literature related to the height of the patient and the lateralization, sir.
In your experience, how many short statured, less than 5 or 5 feet tall men you find in India? Not very.
Yes, sir.
When you make a statement, you should be able to quantify it. Otherwise, it becomes a vague and useless statement. So we have no guideline about using the lateral essay or medial essay. So a short stature doesn't tell me anything at all.
Yes. So basically, it's basically a shorter, in the sense of a smaller anatomical shoulder, sir. It's in that context that they mention a short stature person, sir.
Okay, fine.
Any more questions?
You said there is a lesser chance of heterotopic ossification in lateralized glenoid. Can you explain the mechanism why that occurs?
So with the lateralized design, there's lesser notching, scapular notching, and the stability is more. So
Heterotopic ossification I'm talking about. You
Yes,
said
sir. Yes,
heterotopic
sir. So
ossification. Yeah.
in a medialized design, because of the relatively more notching, that they say that it's relatively more unstable. They say that it's relatively more chance of the heterotopic ossification, sir.
Okay.
Okay, if no more questions, then we'll move ahead. Thank you, Urvil. We
Thank you.
invite Dr. Deepika to start her presentation. We can see your slides. We can
Am
start.
I audible, sir?
Yeah, you're on. Go ahead.
Yeah. So I'm Dr. Deepika Jain, and I'll be talking about cervical myelopathy surgery, evidence-based comparison of anterior and posterior strategies. So natural history suggests most patients deteriorate over 3 to 6 years, yet the condition remains underdiagnosed with discrepancy in observed and model prevalence, with many patients taking nearly 2 years for appropriate treatment. As surgeons, the question is rarely whether to operate. Rather, it is which approach will deliver the best functional outcome. Good imaging does not always dictate good outcome, and controversies exist in decision making. Regardless of the approach, the goals of the surgery for cervical myelopathy is decompression, restoration of or maintenance of the cervical alignment, and preservation of motion. The goal of today's review is to summarize the current evidence, integrate key radiological parameters, and present a practical algorithm while highlighting advances in surgical technique. So the anterior armamentarium that the surgeon has is an ACDF for up to 4 levels, cervical disc replacement for young patient and soft anterior compression with mild myelopathy, corpectomy for large retrovertebral compression, and hybrid construct tailor-made, usually using all permutations. So the posterior pathway that we have is the laminoplasty in borderline or lordotic cases, laminectomy with fusion for kyphosis correction and instability, and laminectomy alone for decompression in high-risk patients. So what does the literature tell us? Large meta-analysis study of more than 2,000 patients over 3 levels in clinical spine surgery and the NAS journal over 33,000 patients show no major difference in post-operative MGOA between anterior and posterior approaches. However, neurological recovery tends to be higher with anterior surgery, likely due to direct ventral decompression. Consistently, vast neck pain and NDI are better after anterior procedure. Posterior surgery tend to cause more axial neck pain due to muscle stripping. Patient-reported outcomes show earlier improvement with anterior surgery, especially within the first 3 months, with equivalence by 2 years. Regarding complications, propensity matching analysis involves more than 74,000 patients indicate that posterior approach have higher systemic complication, higher wound complication, higher readmissions, with more chances of hematoma and axial neck pain and overall complication rate. Anterior surgery, primary complication remains dysphagia. Long-term follow-up data show that although revision rates are generally higher with posterior-only cervical surgery, multi-level anterior procedures for more than 3 levels are significant higher rate of pseudoarthrosis, which often necessitates additional posterior supplemental fixation. Meta-analysis, including more than 22 studies, demonstrate that high incidence of C5 palsy C5 palsy is seen with global fixation more than cervical laminectomy and fusion and least with anterior procedures. Corpectomy procedures and those with higher decompression rate, with especially corpectomy of C4 and C5, are associated with increased risk of postoperative C5 palsy. Comparing anterior to anterior, current evidence favors multi-level ACDF over corpectomy, with current unconstrained implants having higher comparable fusion rates, while ACCF has higher graft subsidence. Meta-analysis suggests better sagittal alignment and lower C5 palsy with ACDF, with no difference in the JOA, NDI, and approach-related complication. So for multi-level ACDF, choose ACDF over ACCF. Multi-level show higher fusion rate in 3-level as compared to 4-level. Skip corpectomy while keeping C5 intact gives better translation stability and fusion outcomes with no need for posterior stabilization, whereas hybrid constructs allow tailored reconstructions with improved biomechanical stability. So for 3 and 4 level, where more than 2-level corpectomy is involved, posterior should always be a surgeon's backup. Posterior surgery, comparing laminectomy and laminoplasty, laminectomy provides the largest increase in canal increase, but this does not necessarily translate into better clinical outcome. Laminoplasty preserves motion, reduces NDI scores. Meta-analysis over 22 studies shows higher rates of C5 palsy with laminectomy and fusion, High T1 slope predicts poor outcomes and post-operative kyphosis in laminoplasty patient. To overcome the pitfalls of laminoplasty and laminectomy with fusion, Hen et al. Introduced a laminoplasty fusion hybrid technique, where the spinous process is used as a bone block for open door laminoplasty. This is followed by posterior instrumentation. Posterior cervical surgery traditionally causes poor axial leg pain and intraoperative outcomes, and hence inferior outcomes in anterior surgery. To mitigate these issues and get comparable outcomes to anterior surgery, several muscle-preserving techniques have been described. The modified Shiroshi technique is one among them, where without paraspinal muscle detachment, skip laminectomy is performed under microscope. Extensor muscle-preserving laminectomy utilizes an interspinous corridor. Haploparaspinal muscle preserving laminoplasty is a landmark modification where the one-sided muscle is detached and laminoplasty is done. The opposite side musculature remains fully intact. Achieves a balance of adequate decompression, motion preservation, and reduced axial pain. To further discuss OPLL, Dr. Felix in his research has clearly said that anterior decompression provides best neurological recovery, but the minimal clinical gain does not justify high complication risk, particularly dural injury and the comorbidity associated. Thus, anterior surgery is recommended only if the canal occupancy is more than 60% and there is a rigid kyphosis or segmental instability. Emerging techniques for OPLL suggest that vertebral body sliding osteotomy allow controlled expansion of the canal after detaching the vertebral body and aligning with plate while maintaining lordosis and reducing the risk of dural tears. But this requires a long learning curve to replicate. The key imaging predictors for surgeons include the K line, negative, which means lesion extending beyond K line, where cord can't drift posteriorly, requires anterior decompression, canal occupancy rate of more than 60%, with a hill type or global anterior compression, with kyphotic rigid constructs require anterior decompression. The modifiers should always be remembered. K-line tilt more than 15 degrees, C2 to C7 SVA falling ahead of the C7 vertebra, and higher T1 slope. The dynamic K-line converting to negative only in extension. All these are poorer modifiers and with poorer outcome with posterior surgery. The 2025 SIMS Severity in Imaging Myelopathy score has been coined this year, a new MRI-based scoring system correlating strongly with the MGO recovery, which incorporates T2 hyperintensity, CSF flow, TOGS ratio, Fujiwara ratio, local kyphosis, and number of stenotic levels. Higher score favors earlier surgery and direct decompression. A practical algorithm for all the young surgeons. Positive K-line, if the patient has positive K-line, less than 3 levels, do anterior. More than 3 levels, do posterior. Prefer a laminoplasty over laminectomy with fusion. Use muscle-preserving techniques to reduce axial symptoms. Currently, anterior procedure with hybrid technique give favorable result for more than 3 level as well. In case of negative K-line, favor anterior or combined corrections. Consider modifier parameters like dynamic K-line, T1 slope, C2, C7, CVA, SIM score. So this is the evidence summary. And to conclude, both approaches give equivalent outcome and should be chosen as per the surgeon's skill and the patient's comorbidity. Still, evidence and literature support earlier and better benefits with anterior approach. Need future larger RCTs to compare muscle-preserving posterior surgery with anterior construct. And the SIM score is an exciting new tool and requires prospective validation. Thank you. These are my references.
Okay, Dr. Deepika, you have exceeded the time a minute. You've taken a minute more. Anyways, questions from judges, please.
Quite a comprehensive study, Deepika, and a little bit on the higher side, because even dedicated spine surgeons are still in the debate whether an anterior or a posterior cervical surgery is indicated where there is established myelopathy. So according to what your conclusion is, the surgeon will decide whether which surgery is ideal for him based on his experience or based on what the K-line or what the parameters are.
So thank you for the question. Definitely the radiological parameters has to be taken care of. Where I meant that the surgeon's experience come into play is with the modified extensor muscle preserving techniques, which are currently not very well practiced in India. and most of the studies were of the Japanese and the Korean population, sir. So to replicate those studies, definitely a surgeon's experience is a must. We are well aware of the anterior and the posterior techniques, sir. So to decide, definitely the radiological parameters should be taken care of, sir.
Thank you.
So, just a comment, despite the best evidence and very critical analysis of so many papers, it's the surgeon's expertise, bias, and training which ultimately decides what he's doing, not literature necessarily.
Yeah, because I think not all parameters can be replicated everywhere as far as facilities are concerned.
The population is totally different. A lot of these paper review things sometimes are not relevant to our population at all.
Yeah, but it's a good review in any case. I think the review
So,
is.
Deepika, can you tell us after you decided to decompress in whatever way you like, is there any difference in the final clinical outcome? I mean, reversal of myelopathy in anterior versus posterior, let's say semi-localized or a two-level disease in a lordotic cervical spine.
So in a lordotic cervical spine, definitely a easier option is as the patient does not require, as the current SIM score, sir, that had major focus on the cervical kyphosis. So in a lordotic spine, definitely a laminoplasty or laminectomy with laminectomy can give good prognosis, sir. But in all of this study, none of the studies said that the outcomes in anterior or posterior with respect to the modified Japanese orthopedic score is different. Only initial 3 months or 1 year outcome with respect to neck disability index or a very bad anterior compression where an anterior surgery would cause good results. Only in those cases, sir, the 2 year outcome of MGOS score has made a difference.
Any more questions?
Is there a way to, quantify your anterior compression as to, after how much anterior compression would you like to go for an anterior rather than a posterior? Is there a limit that you have?
So these parameters, sir, one is the K line, definitely. That if it is negative and it is crossing, then in those cases, a posterior surgery where you depend more on the posterior drift of the cord, it will not work. Secondly, in a kyphotic spine, where the posterior drift will, where the principles of laminectomy, which act on posterior drift, will not work. In those cases, definitely an anterior surgery is required, sir, or a posterior retrovertebral big compression OPLL. In these cases, in OPLL specifically, you have to quantify how the patient is going to react with posterior surgery being more safer than anterior. But all these things need to be taken into consideration.
Thank you.
Thank you, Deepika.
Thank you, sir.
I'll invite the next contestant, Dr. Dhruv Shah. We can see your presentation, Dhruv.
Good
You
evening.
can start.
Thank you for this opportunity from BOS. I'd like to present today extending indications of unicompartmental knee arthroplasty. Are we justified today? So the current scenario is globally across registries, UKR forms around 11 to 15% of all procedures undertaken. In India, that data stands at 2 to 3% and is growing. Western India and Maharashtra perform nearly half of these amount of UKRs. We feel that there is a bias towards total knee due to the fear of revisions, lack of confidence to deliver a successful outcome, and lack of training. 46.9% of Indian knees undergoing total knees are amenable to a UKA. So what are we looking at today? The classic indications, the why extend indications, the evidence for extending indications, and the ideal decision-making algorithm. So the classic indications were given by Cousin and Scott, where they were isolated medial compartment arthritis, no rattle joint tenderness, non-inflammatory arthropathy, ROM more than 90 degree, intact ACL, correctable varus less than 5, age more than 60, weight less than 82, and flexion contraction less than 5 degrees. So what has changed in 2025? We have better implant designs, more technology, high volume surgeon outcomes, patients presenting earlier, incoming cementless implants, and evidence-based long-term data. So the aim of this review is, can we safely push UK beyond the classical limits? Are the outcomes safe and reproducible? How do we select the ideal UKR patient? So this was the methodology through the PubMed database of the last 10 years. So the classic expanded indications are age less than 60 years, higher BMI and weight more than 82 kgs, ACL deficiency, higher activity level, patellofemoral OA, presence of lateral osteophytes, and chondrocalcinosis. So age less than 60 years. Lee et al. Found out identical outcomes, quality of life, and implant survivorships in patients undergoing UK under and above 55 in both groups, which are propensity score matched. Kim et al. Concluded in a midterm follow-up that UK performed well in young activation patients with a survival rate of nearly 95%. Kleblatt et al. In a systematic review concluded UKs had better outcome scores, ROM, and return to activity, but a slightly higher revision rate than total knee. Both had excellent survivorship at 10 years. In the obese, Malloy et al. Concluded from 1,000 knees that BMI should not be considered a contraindication to UK and showed survivorship of more than 90% in all groups of high BMI, with BMI of 35 plus actually showing the highest OKS scores. Agarwal et al. In a meta-analysis of 80,000 patients showed no significant difference in groups with obesity or without obesity for complications, infections, and implant survivorship. ACL deficiency. Due et al. In a meta-analysis of 2,500 knees which had 400 deficient ones showed no significant difference between both groups. Adravanti et al. Concluded patients without clinical instability can benefit from a UK with less posterior slope of 4 to 7 degrees and a fixed bearing design. Zambron et al. Showed in their in vivo fluoroscopic study that reduction of the tibial slope within a fixed bearing implant can compensate for an ACL deficiency, and both groups showed similar kinetic kinematic waveforms throughout their ROM. Bodmer et al. In their higher activity level showed that approximately 2,000 knees after grouping the patients according to their activity levels showed lower revisions, higher activity groups, but which were not significant. Both UK and TK performed well in both groups of activity. Ali et al. Concluded that higher activity does not compromise the outcome of unis and may improve the survivorship and outcomes. Theoli et al. In a review with nearly 2,500 UKs and 7,000 TKs showed no studies reporting deleterious effects of increased physical activity. Patellofemoral OA, Decker et al. Concluded that regardless of intraoperatively visualized or radiographically evaluated PF joint disease, 93% of UKs were satisfied in their functional proms. Lu et al. In a meta-analysis of 4,000 knees found no difference in functional outcomes, ROM, and revision rates between the UKs without PFOA and with PFOA. Both showed excellent survivorship. Joel et al. Showed significant pre-op radiological PFOA does not adversely affect UK outcomes. In the case of presence of lateral osteophytes, Wallstein et al. Showed the lateral osteophytes are not associated with biomechanically weaker or degenerative lateral joint cartilage. Fashionbar et al. Conclude that the lateral compartment cartilage volume and thickness is not influenced by the presence of lateral osteophytes. Hamilton et al. Showed no difference in clinical outcomes at 10 years or implant failure at
What
50
I drop out also.
in subgroups of knees with
So
lateral
silence.
undergoing UK. In the presence of chondrocalcinosis, Moret et al. Showed in a meta-analysis of nearly 4,000 knees that chondrocalcinosis did not significantly influence the outcomes in plant survival as well as radiographic progression of OA. Honeygaard et al. Concluded that 15-year cumulative UK implant survival rates were 90% and 80% for the patient without and with chondrocalcinosis, respectively. Comer et al. In a matched cohort study demonstrated presence of radiological chondrocalcinosis and had similar outcomes in survivorships. 10-year survival was 96% in the chondrocalcinosis group and 98% in the control group. So what does the review of all these literatures say? What is the most important two words? That is patient selection. So what are the current indications? Patient selection algorithm. The patient should have isolated medial-sided pain with a one-finger sign, varus deformity correctable on valgus stress and deep flexion, a clinically intact ACL, a flexion deformity less than 10 to 15 degrees with good further flexion, proper patella tracking, radiographical proof with single weight bearing AP, true lateral X-rays, valgus stress X-ray, patella skyline view and scanogram. The valgus stress X-ray should not show any closure on the lateral compartment. Always consider patient factors and expectations. Indications other than AMOA is AVN of medial femoral condyle, that is SONC. So when you get the indications right, this is what you see in your patients. On the left, you can see it's 6 hours post left uni and 7 years post bilateral stage uni. So to conclude, we can expand our indications if selection is systematic, surgeon volume is sufficient, correctable deformity, PF joint disease is not severe, and ACL is clinically stable. Better to avoid expanding them if affecting more than one compartment, severe PF joint OA, ACL deficiency with instability, and low volume surgeon. Yes, we are justified today by expanding indications for UK when executed correctly by practice surgeons and the correct patient selection. So this is a knee saying, thank you, doctor, for saving me. That's the lateral compartment which we see, which in this case we have actually sacrificed in doing a total knee. These are my references, and I thank you.
Thank you, Dhruv. Questions from the judges, please.
So Dhruv, you know,
Yeah, we can hear you, sir. Go ahead.
can't see you. Uh, Two quick questions. One, you said a clinically stable ACL.
Yes, sir.
Does it negate the need of an MRI proven ACL integrity?
Yes, so that is, thank you for that question. That is a very, currently it is one of the highest topics which is debated, that MRIs generally tend to overestimate the disease. One is ACL laxity. It shows some amount of either mucoid degeneration, which is also actually researched in an Indian topic on Indian patients, that mucoid degeneration and debulking them can help them. The second thing which we also do tend to see in an MRI is, or even if the patient only has medial symptoms and actual medial compartment OA, the MRI would show gross tri-compartmental OA on the report, and you'll see some amount of, even if they say some amount of softening of the cartilage, the MRI report will say tri-compartmental arthritis, and that puts you in a kind of an issue when you do a uni, that you
So
could be.
my question is very clear, Dhruv. Do you need a MRI before you
No,
have a
if you do more
vascular?
MRIs, your uni volume will go down. If it's clinically stable, all of the current indications which are from the Oxford group and from the non-Oxford group, which are the non-designer surgeons, all of them do not recommend an MRI, and a clinically stable ACL is enough to undergo a uni, especially with more and more fixed bearing implants. The clinic, even if there is some amount of laxity, that can be taken up with the fixed bearing implant.
You can take care of the laxity by reducing the slope and the fixed
Correct,
bearing.
sir.
Now, fixed bearing as it is has a lower survival,
Yes.
higher wear, and if you reduce the slope, it will further increase the wear. So don't
these
you
are,
think you are
so these are
compromising
currently the older
on the
consumer.
longevity of the plant?
Yes, sir. So these are older implants, which those datas are. The newer implants, which are the vitamin E enriched and highly cross-linked poly, these do not have that even at a single point where their survivorships across all registries, which are specific to fixed bearing implants, are currently very high. And even currently, if you see the Australian registry and the American registry, they're all switching from a mobile bearing to a fixed bearing implant, even with this scenario. So one of that is because it is robot matched, and the second one is because of the vitamin E enriched and highly cross-linked polys. The point where, which is a single point of contact between the poly and the femur, that problem has now reduced.
Uh, Good presentation, Dhruv. One question. When you say the change of slope, usually you are doing it only half of the knee. The remaining knee is the native slope which is there.
Absolutely, sir.
So then how do you justify that the ACL or the deficiency is going to be taken care of only by, correcting half of the knee slope while the remaining half is going to be, and how much can you do that by?
So currently, sir, what we do uni, we're only exposing the middle half, and the middle compartment, the reduction of the slope according to the kinematic waveforms. There was one paper in which they studied this on a intraoperative fluoroscopic study, and they show that reducing the slope by 4 degrees, that is around between 4 and 7 degrees, the kinematic waveform and the complete flexion till deep flexion of the knee was the same. However, I do agree that yes, the lateral compartment slope is going to still be the same and the native one, but because of the pivot point being on the medial side, that does take care of most of our problems.
Okay. The second question is osteoporosis going to be a contraindication or an indication, or will osteoporosis be an extended indication in the current scenario that you're talking about, or would it still be a relative contraindication?
So in the current scenarios, there are some papers which do say that in severe osteoporosis, they do advise still going for the total knee. And if the patients are going for if you do assume that you are going to be at a requirement of a stem, then yes, the uni stands as a contraindication. But some of these newer papers, which are also saying that because of the increased activity post a uni, the osteoporosis also tends to decrease. And the second thing is most of these patients which are now coming under the younger group of the expanding indications, the osteoporosis problem is a little lesser pronounced.
Thank you.
There's an Indian study also which is more than 2,500 patients, and they do have good long-term survivals. So relatively, the Indian studies which are more osteoporotic patients are still also doing well.
So, Dhruv, one question: with the popularization of knee preservation surgery,
Yes, sir.
how does your extended indication compare to doing a high tibial osteotomy by whatever way and
Correct.
preserving the native knee?
Yes, sir. So currently, sir, in the most of our expanded indications, still the one of the clear indication is bone-on-bone arthritis as KL grade 4. So the bone-on-bone arthritis becomes one of your main indication, whereas still in a younger patient with grade 2 and grade 3 high tibial osteotomy still stands as one of the one of the better opportunities. But currently across all registries, even in the US, obviously there's no high tibial osteotomy registry which is directly mapping it, but according to they have gone through their claim registries and they've seen that there's a reduction of high table osteotomies occurring every year, which is approximately 20%, and is an increase by 50% every year of uni volume. That is because of the fact that unis tend to be a little more predictable. But how younger age patients with no bone-on-bone arthritis, high table osteotomy still stands as one of the gold standards.
Okay, thanks.
Thanks, sir.
Thank you, Dhruv.
Thank you so much.
We'll invite our next participant, Dr. Nrupam Mehta, to share. We can see your presentation. Go to slideshow mode and you can start.
Okay.
Yeah, we can see that. Start.
Am I audible?
Yeah, you're audible. Start.
Good evening, sir. So basically, I'm Dr. Nrupam Mehta. I'm working as a spine fellow. My today's review of literature is on neutral or dynamic MRI for cervical radiculopathy. So basically, I'm going to go over some case scenarios. This is a patient who's a 42-year-old male. He's complaining of severe left radiculopathy. To minimize his symptoms, he's had his arm over his head. As you can see, this sagittal T2 image is radiologically correlating with the picture that I have presented, and it all adds up. What happens is if this same patient shows up with this MRI, where you're not able to clinico and radiologically correlate of why this patient is in such pain, and then you start wondering, am I missing something? Do I need to disregard his pain? Do I need to evaluate further? That is the query that we face in OPD. So this is another case scenario. This is actually an international athlete's MRI where he was unable to play during his matches. Many spine surgeons went through his MRI and they didn't see any significant compression, and they kept wondering what was happening. Another spine surgeon stepped in and ordered a dynamic MRI, and as you can see, it's in flexion, and you can see a C5 C6 prolapsed disc that was actually bothering the player. The player was benched for some time till he recovered, till he recuperated, and was happy that we had actually found the pathology. So just going over the basics, what is a neutral MRI? A neutral MRI is a scan of the cervical spine performed with the neck in its natural resting position. It is done to assess disc herniation, spinal canal diameter, nerve root compression, cord signal changes, and facet ligament pathology. This is again a T2 cart. It's labeled with the spinal cord, CSF fluid, anterior posteriorly, C5 vertebral body, C6, C7 disc. Now, what is a dynamic MRI? So, MRI of the cervical spine formed in positions typically flexion or extension. Basically, maximum flexion and maximum extension that the patient can tolerate. Extension is basically brought about by keeping a bolster at the shoulder blades, and flexion is mainly brought about by keeping a bolster just below the neck. It helps with extension-induced spinal canal narrowing. It also helps in checking of buckling of ligamentum flavum, dynamic cord compression in cervical myelopathy cases as well, and dynamic foraminal stenosis. You get a lot of data because of this MRI. So the aim of my today's review is to determine how often what are standardly practiced neutral MRI underestimates or misses clinically significant cervical spinal canal or foraminal stenosis, and when should we actually order a dynamic MRI, and what are its indications in OPD. So the method have undergone electronic databases, PubMed, PMC, Scopus, Google Scholar. We use keywords such as dynamic MRI, flexion extension MRI, cervical radiculopathy. And I have included a lot of prospective studies, systematic reviews, case reports, meta-analysis, and finally studies with higher citation were chosen for the final review. So there are a couple of articles that I have pointed out. So this was one of the role of kinematic MRI for evaluation of cervical myeloradiculopathy. Basically, it was published in 2018 in the Journal of Spinal Surgery. And what did they say? They basically said that 16% of the cervical radiculopathies were missed. As you can see, the summary of this result, radiculopathy was present, but neutral MRI showed no cord compression, and it having 16.6%. Even patients which did show a little bit of stenosis, they had increase in cord compression extension, and that was almost 76.66%. They actually underwent ACDF, and the next group of people also had to go surgical intervention, which on a neutral MRI you would consider conserving. So this is the next article which was published in Biomed Research International. It was basically where patients who did have C6 radiculopathy but neutral MRI, again because it's done in static position, was not able to pick it up. They evaluated the dynamic foraminal stenosis on the MRI. As you can see, the big black box here, it's the neutral. So 69% of the patients were picked up on this. This is the extension MRI that 71% showed foraminal stenosis, and these are the same patient. And this is the flexion position, where again 68% of them were picked up. My next was one study that was published in the Egyptian Journal of Neurology in 2023. It basically assessed what is the added value of dynamic MRI and assessment of cervical spondylodegenerative diseases. So what they said was that 80% were detected by the neutral MRI or the normal MRI, but 20% was not detected, which was only detected on dynamic MRI. And this study was conducted in almost 180 patients. So the next one is, again, as I had read through the review of literature, everywhere it showed that dynamic MRI was definitely picking up more than the neutral MRI. But I did come across this one study which also suggested all of the studies, but they showed that there was a limitation to dynamic MRI as well because of motion artifact and poor quality image. So I have analyzed 12 different papers. There were not too many on radiculopathy per se. It's still an evolving concept where doctors are still a little hesitant on prescribing the dynamic MRI. A big study was by Fujimoto in the Journal of Neurosurgery of Spine, where they said that with symptomatic dermatomes, it did detect more than neutral MRI, even if the MRI showed nothing, no compression. It also helped in improving level selection. You may see one level, but when you see dynamic, you may see more than one level, which may need to be fixed, and we could miss intraoperatively. Then another one, as we've already seen, is the Egyptian Journal of Radiology, added value of dynamic MRI and detecting lesions not visible on neutral MRI, and it showed hidden and central and foraminal stenosis. Next I will go is through my review of literature. It also said that motion artifact was the biggest. It showed degraded image quality in at least 13 to 16% of the patients. We don't have a standardized protocols. We don't know how much flexion across the board, how much extension across the board, the obliquity of the cuts, the obliquity on sagittal, and the patient is in severe discomfort. Flexion extension maintaining for almost 10 to 15 minutes at the minimum is very difficult for patients. Limited availability. So not all hospitals have a big gantry size which can accommodate the flexion and extension position of the neck. The gantry size is not big enough. Also, longer scan times, it becomes more expensive. So a way to maneuver around this, which I was thinking during my review of literature, could be we just evaluate T2 images. That could reduce our time. And of course, we can't perform it in acute trauma. It's too painful. We don't know the neurology status. So, from my review of literature, I would say that we should not hesitate to investigate if something is not matching. It's better not to disregard it or to underplay it or to find other possible reasons to that patient's pain. So, if there's a clinical radiological mismatch, get to the bottom of it. Dynamic MRI adds diagnostic value, especially useful in patients with persistent symptoms, radiculopathy, but inconclusive static MRI. Frequent discogenic injuries with neutral MRI and chronic radiculopathy, you should definitely think of advising the patient a dynamic MRI. These are my references. Thank you.
Thank you, Rupam. You took 1 minute more than they expected. So, questions from judges, please.
So, Dr. Nrupam,
Yes, sir.
you said that there are certain cases in which, even in normal MRIs also, if you see, there are a lot of degenerative changes, if I might use the word,
Yes,
which is seen in an MRI.
yes,
And most of these patients are usually asymptomatic.
yes, sir.
Correct. So then if there is something that you see on a dynamic MRI, how do you know that it is actually the main cause of the symptom and not a natural variant of the MRIs that we usually see in various age groups?
So, obviously, we always treat the man and we don't treat the scan. So, if there is no clinical radiological correlation, again, if it's just a process of the natural history where the patient is asymptomatic, I would not do anything. I would just observe him till he became symptomatic or if he showed any other complaints. But yes, if it was reverse and the patient is asymptomatic, MRI is looking bad, I would wait. I would not do anything about it.
So, any study on overdiagnosis caused by a dynamic MRI or unnecessary surgeries attributed to the dynamic nature of the MRI?
So I've not come across any study yet that we are over treating, as there's very limited, even on dynamic studies yet. There were hardly, around 20 to 21 papers, but they were not suggesting that we are over treating. They have not commented on that, sir.
So, Nrupam, can I ask you a question? When you say dynamic,
Yes, sir.
do you mean in the true sense of the word dynamic, like an ultrasound where you can real time see the cervical spine moving, or it is like a dynamic X-ray where you do a study in flexion and then in extension?
Sir, I mean it in the flexion and extension way, not in the real time, sir.
So is
Sometimes,
it dynamic?
yes, sir.
I don't think the MRI is designed to show you live images. It has to be one in flexion and one in extension. Dynamic, it should be rather be termed as a loaded or a symptom producing
Bent.
position rather than a dynamic, the true dynamic MRI.
Yes, sir.
Okay, thank you, Rupam. I'll invite the next participant, Dr. Adit Maniar, to share. We can see your presentation, Adit. You can start. Adit, you're here? We can't hear you.
Aditya, muted. You have to unmute yourself.
Okay, sorry. I'll restart there.
Yeah, you
Good
can
evening,
start.
everyone. I would like to thank BOS and the entire organizing team for giving me the opportunity to present today. My topic is joint line obliquity, impact on outcomes of high tibia osteotomy for management of varus deformities. In the young varus knee, high tibial osteotomy improves clinical function and delays the progression of arthritis. There are multiple factors that can affect the outcomes of HTO, with joint line obliquity gaining a lot of importance more recently. But what is joint line obliquity, or JLO? JLO basically refers to the orientation of the joint line, which is independent of the overall alignment. If you see these three images, the purple line denotes the alignment of the lower limb, which is the same in all the three limbs. But the green line denotes the joint line, which is horizontal in the first image and oblique in the other two images. Why is this important? Multiple biomechanical studies have shown that an increased joint line obliquity increases the shear stress and alters contact areas and meniscal loading, which can lead to an increased progression of arthritis. But why is there an increased JLO after HTOs? It's important to understand that not all varus deformities are in the tibia. And so what do you do to avoid an increased JLO? Double level osteotomies are shown to maintain JLO much better than an HTO alone. But they have their own downsides. There's an increased chance of morbidity, increased chances of complication, operating time, and cost due to an increased need for implants. So that brings us to the aim of our presentation today, which is to provide a narrative review on the impact of increased joint line obliquity on outcomes post-HTO for a varus knee. I reviewed multiple databases and references of relevant articles, included all types of studies, excluded articles before 2015 and those not in English. There is a wide variety of techniques which have been used to measure JLO, with no consensus on which is the correct one. The most commonly used ones are the JLO-AF, which measures the distal femoral orientation relative to the horizontal, JLO-AM, which measures the orientation of the middle of the medial and the lateral joint space with relative relation to the horizontal, JLO-AT, which measures the proximal tibial orientation with relative relation to the horizontal, the MPTA or the medial proximal tibial angle, and lastly, the Mikulicz joint line angle. Coming to our results, I'm going to divide the studies into two types. One is the comparative studies, which have made two groups based on JLO cutoffs. Majority of these studies had a sample size less than 100. All of them were retrospective studies, with only two studies having performed a lateral closed wedge. MPTA was used as a measure of JLO in all of the studies. And the two groups were formed on different cutoff points for MPTA, ranging from 95 to 98. The minimum follow-up ranged from 1 to 5 years, with only one study having a minimum follow-up of 10 years. Only two studies found poorer clinical outcomes in the group with an increased JLO. No study found any difference in survivorship in patients with an increased JLO. Looking at the studies which looked at the correlation between an increased JLO and clinical outcomes, majority of the studies here again had a sample size less than 100, with only one having a sample size of 463, which was a good number. Again, all of them were retrospective studies. Only one study performed a lateral closing wedge. The minimum follow-up ranged from 1 year to 5 years. Only two studies had an average follow-up of more than 10 years, with none of these studies having a minimum follow-up of 10 years. JLO-AT was the most commonly used form technique to measure JLO, but there was a wide variation. Looking at the results, only 3 studies found a correlation between increased JLO and poorer clinical outcomes. Out of these 3, only one excluded overcorrection. Overcorrection is important because by itself is a risk factor for poorer outcomes after an HTO. Only one other study excluded overcorrection, and this study found no correlation between increased JLO and poor and clinical outcomes. This systematic review in KSSTA in 2023 found that based on current evidence, the actual association between postoperative JLO and clinical consequences after HTO for medial knee osteoarthritis could not be ascertained. They concluded that the clinical relevance of JLO after HTO remains controversial. This expert consensus statement in KSSTA in 2024 looked at osteotomies for painful degenerative varus knees and graded recommendations from A to D. There was one statement related to joint line orientation, which was planning should aim to target a resulting knee joint line orientation below or equal to 5 degrees or an MPTA less than 95 degrees. They had a grade B recommendation, which means scientific presumption only. So what does this all mean? I think there is good biomechanical evidence to support uh, that increased JLO would affect outcomes, but its effect on clinical outcomes and survivorship is uncertain, which might be possibly due to majority of the studies being retrospective, multiple different techniques of JLO measurement, differing outcomes or endpoints in all the studies, and majority of the studies having only a short follow-up, with only one study having a minimum 10-year follow-up. So does that mean you can ignore JLO as of today? The absence of level 1 evidence does not mean that there is one way or the other. I think today, if you're planning an HTO and the predicted post-op JLO is more than 6 degrees or MPTA is more than 95 degrees, have a look at the femur. Is there a varus deformity there? Are you indicated for a DFO or a DLO? Look at the post-operative alignment. Are you overcorrecting? And are you making a very large correction, maybe more than 15 millimeters, and land up with problems of non-union or patellofemoral issues? So consider this before proceeding with your HTO. These are my references. Thank you.
Thank you, Adit. Open for judges for questions. Jayesh, you can start on this if you're here, or Thakur sir.
So I wanted to ask you that this is a nice presentation. Did you try and find out in the failed HTOs in which the correction was correct and your alignment was correct, but they failed because of an variation in the joint on obliquity? Are there any such studies which are there?
Yes, sir. So I think that's what I meant when I said only 2 studies, and all of them excluded those with an overcorrection. There were only 2 studies. One found that the joint line obliquity, increased obliquity was associated with poorer outcomes. The other one did not find any difference.
Okay.
Now, the joint line obliquity doesn't affect the clinical outcome. So why should we worry about joint line obliquity at all?
Yes, sir, I agree. I think so far the evidence does not show any difference, but all of the evidence is all retrospective. So there is no level 1 evidence to suggest one way or the other. And I agree that there is no evidence right now to say that it affects the clinical outcomes.
Is there any experimental evidence where somebody has run a
Yes, sir. There are multiple. Yes, sir. There are multiple biomechanical studies, well done biomechanical studies that show that the cartilage forces, the shear stress, and the loading patterns are different when the joint line obliquity is increased.
Yeah, but the body can adapt to these newer forces and change your cartilage orientation accordingly. I think you're right in saying that clinical relevance is not there, and getting level 1 evidence to this effect, even in the long term, is going to be difficult.
So Adit,
Yes, sir.
one of the lectures I had heard is that you can end up in a post-operative joint line obliquity if you have some lateral laxity.
Yes, sir. Sir, I think so. That basically means you've overcorrected it because of your lateral laxity, and I think now there are softwares, but also there are formulas where you can control for that, which is what I was trying to say at the end. That if you find that in your plan you are going to have an increased joint line obliquity, go back to your plan and make sure you're not actually overcorrecting that patient, or there is something else that you have missed before you actually do only an HTO.
What is your definition of overcorrection?
So overcorrection, sir, there is no fixed point. As I said, people have used different measures of joint line obliquity. If you look at JLO8T, which is the tibial orientation to the horizontal, the most commonly used number is 6 degrees. So if you're if you're going to be more than 6 degrees to the horizontal, or if you're going to have an MPTA more than 95 degrees, that range varies. Some have proposed 92, some have proposed 98.
Okay, any more questions? If not, Dr. Shubham, you can share your presentation. Thank you, Adit, for
Yes.
a nice presentation.
Thank
So
you.
Shubham is the last candidate tonight. Shubham, go ahead. Yeah, go in the slideshow mode, and yeah, we can see that. We can't hear you yet. Soham Ranade. Soham, we can't hear you yet.
Sir, am I audible now?
Yeah, you're audible now. Go ahead.
So just a minute, I'll make it full screen.
It is full screen for us. We can see it, Soham. So,
Yes,
you
sir.
can
So
go
my
ahead.
slides are not moving. I'll just
Just tap on the screen once with the mouse, and then it will start moving.
is it moving now, sir? Hello?
Yeah, it is moving.
Okay. Yes. Okay. Good evening to all. At the outset, I would like to thank the Bombay Orthopaedic Society for giving me this opportunity. I'll be talking on, does arthroscopic rotator cuff repair provide superior results as compared to a mini open repair? Now, is it a narrative fallacy? Are we having a cognitive bias which is leading us to make poor decision making? In the recent review of brochures for multiple conferences, in this 3-day conference at ISCON, there was only a single lecture on the mini open rotator cuff repair, and there was no such lecture in the last YROC. So there's just one question. Are we having a complicated arthroscopic repair for a simple option, which is the open repair? Is it because there are newer appliances, newer devices by which we are taking this decision? When we want to know the result of a rotator cuff tear, is it because of the quality of repair or the method? Taking these questions into consideration now, let us see what the literature has to really say. Now, I have taken multiple level 1 and level 2 studies, the last 15-year papers, Google Scholar, PubMed, and Embase as the databases, and high citation index articles have been cross-referenced. My objectives were simple. I wanted to know when did the transition begin from a total open repair to an arthroscopic repair, to compare the outcomes between the two methods, to know the time for surgery and the cost analysis between the two methods, to know the learning curve and the cosmesis. Does it really play a role? Pain scores and stiffness between the two methods post-operatively, re-tear rates, how do we do RCT at our institute, and the choice of surgery in 2025. Now, the evolution of arthroscopic rotator cuff repair began as basically a diagnostic scopy modality, followed by arthroscopic assisted open repair, and then moved on to all arthroscopic repair. The advantages which were put forward at that time over mini open repair were smaller incisions, faster recovery, and better outcomes. Do they hold true even today is what we are going to know. Now, in this article, comparing the early outcome measures for mini open versus an arthroscopic repair, it gave marginally better outcomes for arthroscopic repair only in the early postoperative phase. However, at 1 year and 2 year follow ups, there was no significant difference. At 1 year follow up in this RCT, it showed similar outcomes. Even in this meta analysis, there were no differences in the outcomes at 2 years of follow up. In this meta analysis, it gave again similar outcomes with a constant Morley score being slightly better for mini open repair as compared to arthroscopic repair. Now, this is an important landmark randomized control trial of the UK, the UCUF, which gave effectiveness of open versus the arthroscopic rotator cuff repair. Again, there were no differences in the outcome measures between the two modalities. A recent paper published just last month in November 2025 by Raiju Vaishya et al. Stated that they had comparable clinical, functional, and patient-reported outcome measures with the mini-open approach, having a marginal advantage in the operative time. Otherwise, both of them were pretty much the same. The time for surgery is much less for a mini open repair as compared to an arthroscopic repair. As we can see in the median OR time, the time gradually reduces for arthroscopic repair in a high volume center as opposed to low and intermediate volume centers. Now, cost, does it play a role? Yes, most definitely. Especially for Indian patients, it is of much significance. It is said that it is about $1,144 less expensive, the mini open one, as compared to an arthroscopic rotator cuff repair. So, for a similar procedure, so 4 lakh or 250, the decision is on us. Now, an interesting study on the rotator cuff repair market summary, it is stated that it is estimated to reach about 1689 million US dollars by the year 2033. So, the choice of doing an all arthroscopic repair, is it driven by patient or driven by something else, is the question we have to ask. A great article by Stephen Burkhardt himself stated that the burden of craft in arthroscopic rotator cuff repair is much more than a mini open repair. He stated that mini open repair is easier to do and master. Arthroscopic has a steeper learning curve. So whatever you do, essence is do a good rotator cuff repair. Good either by arthroscopic or by mini open repair. Is cosmesis an issue? Not really. For elderly Indian population, they are not going to wear clothes like these, so it is really not much of significance. What about post-operative stiffness? Does it play a role? Not really. Mini open repair does not cause intractable stiffness. There were no cases of deltoid damage. However, the retear rates were much more for arthroscopic repair as compared to mini open repair. Now, how do we do it at our center? We mark the landmarks as seen here. An anterior clavicular line is taken and about 5 centimeter incision is drawn. We do local infiltration with adrenaline to prevent bleeding. Strategic retrieval of sutures is made from the cuff after deltoid split approach. Crisscrossing of sutures is done and a horizontal tunnel is also made to enhance the strength of the fixation. The closure is done, and at 6 months of follow-up, we can see nice patient-related outcome measures, good shoulder ROM, forward flexion, and external rotation, as is evidenced in these images as well. Subscapularis, another point being put forward by many arthroscopic surgeons that causes that it is less visualized by mini open repair. We can nicely see the subscapularis. Sutures are again passed through the subscapularis, and after complete closure, we can see good robust coverage of the subscapularis as well as the supraspinatus, as is evidenced here. So the take-home points of my talk were: mini open repair has similar outcome measures as compared to arthroscopic repair for rotator cuff tear. The retear rates are much more for arthroscopic repair as compared to open repairs. Mini open is simple, cost effective, and a faster procedure, providing constant results. After these summary of review of literature, if you have the same chai now, I put forward the question, which would taste better? The choice is yours. I put forward the question. These are my references. Thank you so much for your patient listening.
Thank you very much, Soham. Questions from judges, please.
So, Soham, that was very interesting. I have one question. When you say
Yes, sir.
mini open, do you mean a diagnostic scopy followed by mini open or a mini?
No, sir. There's no diagnostic scopy, which was done earlier. The transition phase between a total open to a total arthroscopic was a arthroscopy assisted mini open repair, in which they first put the scope to check the intra-articular pathologies. Here I mean a total mini open repair without an arthroscopic system.
So, don't you think you might miss a labral tear or something which the MRI has failed to report, and your patient may still be unsatisfied?
Yes, sir. So I went across the literature, sir, for surgeons who advocate open and mini open procedures over arthroscopic. What they had to say, sir, is that in current day and age, shoulder pathologies can be diagnosed by a thorough clinical examination and a good MRI reading, and therefore the labral injury or a suspicion of labral tear is a preoperative decision. Even if you have a slight doubt of a labral pathology or an intra-articular pathology, the decision is clear. You have to go ahead with an arthroscopic repair as opposed to a mini open procedure. So it is predominantly a preoperative decision after evaluation of the MRI and the clinical examination, is what the surgeons had to say, sir. So for a pure rotator cuff tear, it doesn't matter. Of course, intra-articular pathologies, there's no other option apart from a scopic repair.
So, Soham, the visualization in an arthroscopic repair of the footprint of the rotator cuff is much better and much more wider as compared to in an open. So in an open, how do you decide which footprint the cuff sits in?
Sir, so for the open repair, we put the anchor at the articular margin. So that is the footprint which we have taken. It is about 1.5. It is less than 1 centimeter from the articular margin. So that is the footprint which is taken. We medialize the footprint if the cuff is massively retracted. So for a mini open, we have had better visualization of the footprint as well, as opposed to a arthroscopic modality. Also, sir, in few articles I came across the bloody field decisions about the intraoperative hypotension for elderly are the factors which can come causing a poor visualization. Definitely, it has a clear visualization, but it is not bad even for a mini open repair.
So in your series, the ones which you have operated by mini open had only rotator cuff tear and no other injuries or no other lesions inside the shoulder joint of the entire series, where how many subset or what percentage of subset were these patients?
Yes, sir. So the comparisons were done only for the rotator cuff tear, avoiding and excluding all the intra-articular pathologies because the bias becomes more in favor of the scopy. So only pure rotator cuff injuries were taken. The degenerative and the traumatic ones were compared for both the types of procedures, the mini open and the arthroscopic modality. An intra-articular pathology becomes an exclusion criteria, so became an exclusion criteria for the studies.
Okay. Any more questions?
Yeah, so sometimes there are only articular surface tears which are there, which cannot be visualized from the mini open. So would that be a contraindication for a mini open, or you would still like to go for them also with your mini open technique?
Yes, sir. So, sir, similar queries were put forward in multiple papers as to pasta lesions, the partial articular surface lesions. How does mini open prove equivocal to an arthroscopic repair? So, the comparison they gave was that we can just reflect the bursal surface of the rotator cuff, and we can address the articular pathology and cover the bursal surface. They gave the comparison between a humerus nail, wherein there are no reported differential outcome measures for a bursal and an articular surface tear. There is no correlation. They correlated the two. So it does not play a significant role even if we reflect the bursal surface, suture and repair the articular surface, and come back again and suture the bursal surface. The comparisons were given for an intra-articular, the humerus entry point. There, the people said that we propose a mini open, minimally invasive humerus nail, which is again piercing the rotator, both the surfaces. But that has again proved not of much significance later. The patient-related outcome measures have not been affected even if we have gone through the rotator cuff, both the surfaces. So bursal surface reflecting, repairing the articular surface, and again coming back and repairing the bursal surface. So that is not a contraindication.
Okay, thank you.
Thank you, Soham. I think we
Thank you,
come
sir.
to an end of this round two. I'd like to thank all the judges for staying back for it's quite late in the evening. And I'd like to thank all the contestants also. So thank you very much, and we'll have the results within next few days, and we'll have the final round during VIROC 2025. Thank you, everyone. Good night.
Thank you. Thank
Good night. Thank you. Congratulations, everyone.
you. Good night.
Thank you, sir. Good night.
Good night.
Thank you, sir.